At this point in time, I'm going to turn it over to Dr. Niazi to start his lecture. Khusrow, it's your time. Please.
Thank you very much, Umar. First of all, let me thank Professor Lattouf, who has done a tremendous job in bringing this thing in the forefront. And I think this is just the tip of the iceberg, because knowing the energy that Dr. Lattouf has, I think this is going to grow tremendously to the benefit of healthcare providers and for our patients. So, Umar, I would like to dedicate this next 25 minutes of my talk to you for your tremendous work you have done. So, welcome, good morning, good afternoon to people in Jordan. It's a great honor to be speaking to you. If you want to stop me anywhere, please feel free. I know it's difficult to do the interaction, but Umar said that he will unmute you if you have any questions. I'm going to cover this topic, which normally I give over an hour in 25 minutes. So if I go too fast, I apologize. But I hope in the future we can have more of these sessions and more interactive sessions where we can discuss patients and come up with the best plan. So as we all know, when we are dealing with patients with coronary artery disease, many of the times, especially the cardiologist, we just start focusing on the heart, and we forget that the patient is from head to toe. But remember, atherosclerotic disease is just not limited to the heart. It extends from the head down to the toes, can affect any of your arterial system. And this remind you that this can affect the cerebral, the peripheral arterial disease, and hopefully I will show you some cases which will convince you. But especially for cardiologists and also for primary care physician and other specialties, we have this elephant that is sitting out in our waiting room with peripheral vascular disease, and unfortunately, and recognition is very simple, and my job is in the next 20-25 minutes to make it simple for you. So let's start. I think that's the best way I can show you how you can recognize this disease. These are real patients that came to my clinic, and I've taken out their histories and just presented to you. So a 56-year-old female who comes because she was complaining to her doctor that her legs get tired at the end of the day, and she has significant cramps at night time. Now she plays tennis twice and is feeling well otherwise. She has history of high blood pressure, a strong family history of premature coronary artery disease, and on further questioning, she acknowledges that sometimes she drops things for no good reason occasionally. So when you look at this type of a history, the things that should come to your mind are going to be the legs getting tired at the end of the day and significant cramps at nighttime, because that probably indicates that she may have chronic venous insufficiency. But we were able to also ask her questions, because when we see patients, we screen them from head to toes, and believe me, it takes us less than 2 minutes to screen patients from head to toes for any heart and vascular disease. So she gave us the history that she, yes, drops things for no good reason. Well, what that should bring to your mind is what is called transient ischemic attacks. And these are sudden development of any of these symptoms that I've listed over here. And I won't read them all because I think most of you know what transient ischemic attacks are. But if you think of cerebral circulation, that is the blood supply to your brain, carotid artery disease can manifest itself as either asymptomatic, which is most common, or they can manifest itself as TIAs or transient ischemic attacks, which are basically neurological deficits that last less than 24 hours. Or you may have retinal ischemic events, like loss of vision, transient in one eye, as if a curtain fell down, what is called amaurosis fugax, or central retinal artery occlusions or branch retinal artery occlusion, which the ophthalmologist will send you patients saying that they have noticed that. And finally, you may present as ipsilateral ischemic stroke, which is the sad part, which our goal should be to stop these from happening. So what test to do when you have a patient who comes like this and gives you this history, which may suggest that it is a TIA? Well, it's a very simple test called a carotid duplex ultrasound. And I think all of us physicians should be very comfortable with this thing. Remember, when we do carotid duplex ultrasound, the standard is that the feet is going to be on the right side and the head is going to be on the left side. So this is the common carotid artery that bifurcates. This is the external carotid artery, and this is the internal carotid artery. And you can see there's an atherosclerotic plaque over here, which is not yet calcified. And there's some lucency over here, which worries us because echo-lucent areas in the plaque have a higher risk of TIAs and strokes. And this is the velocity. Basically, you are seeing how fast the blood flows, and that's how we diagnose stenosis anywhere in the body with ultrasound. So it's a very simple technique. And you can see the peak systolic velocity is 268 centimeters per second with a diastolic velocity of 119. Normally, your diastolic velocity should be under 30 centimeters per second, and your peak systolic velocity should be under 80 centimeters per second. So significantly elevated velocity, suggesting a significant stenosis. Many people will ask on examination, what about carotid bruits? Well, carotid bruits, if they're present, that's fine. They may suggest atherosclerosis, but their sensitivity and specificity in patients who have significant stenosis is not that great. So if your patient does not have a carotid bruit, does not mean that you have ruled out carotid disease. It is far more important, the history, and that's where I encourage the younger physicians to spend more time, because history taking, I think, will give you a 80 to 90% of an idea what the patient may have underlying. Carotid bruits can be caused by multiple other things besides having a stenosis in the carotid artery. And this is what the patient's stenosis, so you can see the blood supply, common carotid artery bifurcates in the internal carotid artery, has a tight stenosis. And I told this lady who was in her 50s that we are going to first fix this, and we placed a stent over there, which took us about less than 30 minutes to do that, and the patient had successful to go back the next day from the hospital. And then we addressed her legs. So just briefly, cerebrovascular accidents, the third most frequent cause of death, and it's the number.
It seems like we may have lost the voice on Dr. Niazi. We may have lost the voice on Dr. Niazi. What happened? We may have lost. Do you have Hebron University? Do you have the signal on Dr. Niazi? Can you hear him?
We hear you, but we don't see any pictures. Any...
Do you hear Dr. Niazi?
No, we don't hear him.
Okay, yeah. Let me call him and see. Something has happened on his side that we lost his voice. Let me see.
Hello, Omar, can you hear me?
Now I hear you. We lost you for a minute.
Oh, do you want me to go back?
Go back 4 slides, please. We lost the signal for some reason. Go back.
Okay, tell me where to start.
Okay. Yeah, right there. Move forward. Move forward. Move forward. Move forward. Go there. Yep.
I just want to bring it to your attention that we don't see the pictures yet.
Okay. We will wait till you see the picture.
Not yet.
Let me see if I can.
Khusrow, I'm going to turn off your video and okay.
Okay.
Khusrow, I'm going to turn off your video, but your slides will show.
Turn it off. Turn it off. Good.
Can you see the slides?
Okay, now we see you.
You can see, and can you see the slides?
Actually, we see nothing now.
You see nothing. Okay.
But we hear you.
You hear me only. Well, no, I think we need to show you the slides.
You are back.
Okay, can you see the slides?
We don't see the slides.
Dr.
Okay.
Khusrow, could you please start sharing your screen again?
Khusrow, share your screen again.
Please.
Okay.
Yes.
That, I mean, are the slides coming across?
Yes.
Okay.
We see
Okay, everyone can
your
see the
slide.
slide?
You may
You see the
proceed.
slide in the background?
Khusrow, you may proceed.
I'm sorry?
You may proceed. We see you and see your slides.
Okay, I'll make it bigger then. So, my apologies. So, basically, when to do an ultrasound, you should have a low threshold of getting an ultrasound in patients who are greater than 65 years old, and especially if they have other vascular disease. If they have left main coronary artery stenosis, that has a high association of carotid artery disease. If they have significant peripheral arterial disease, or they are a heavy tobacco user, or if they have a brewery on physical examination, or if they give you any clues of a TIA or a CVA, then I think getting a carotid ultrasound is a good choice. Now, when to be concerned about TIA, there was an article published by Johnson's group in Lancet where they gave a score. So if your age is greater, or if your blood pressure is greater than 140 over 90, you get a score of 1. Now, if your symptoms is weakness on one side, you get a score of 2. But if you only have speech difficulty, you get a score of 1. And then the duration of symptoms, you get a score of 2 if your symptoms have lasted more than 60 minutes. But your score is, if the symptoms last less than 10 minutes, then your score is 0. And for diabetes, you get a score of 1. When you add these scores, if your score is less than 4, then your chances of having a recurrent TIA in the next 48 hours is less than 1%. But if you're greater than 5, then your chances of having another TIA in the next 48 hours are high. So it's prudent to admit those patients with a high score, and you may send home the patient with a low score with optimal medical therapy, and we'll talk about that in a second. So let's talk about treatment. The optimal medical therapy, has changed since over the past many years, and definitely we have to encourage our patients about smoking cessation, weight loss, what Omar was mentioning earlier about the cardiometabolic syndrome, which is an epidemic, and encourage our patients to get into some regular exercise program on a daily basis. Also, we need to address the risk factors, including diabetes, high blood pressure, cholesterol management, and finally, antiplatelet management would be the best way to treat these patients. If they need surgical treatment, we have two choices: carotid endarterectomy, which has been done for past 50 years, and then carotid stenting that has been going on for past 20 years. And both of them have their advantages and disadvantages, but due to time, I'm not going to spend much over here. But carotid stenting can safely be done in people who are pretty well aware of this procedure and can be very good for the patients as it's not a major surgery. Let's move on to patient number 2. This is a patient who came to me last June 28, 2014, a 77-year-old gentleman who was a former CEO of a large company. And unfortunately, after he retired, he developed a non-healing wound on his left leg above the medial malleolus for the past few weeks. Unfortunately, his right leg was amputated in North Carolina in October 2013. He also has diabetes, hypertension, a history of pericarditis, and had a systolic murmur which was suggesting to me aortic stenosis, though nobody had told him about that. Now, what do you do with this type of patient? Well, we are always taught that if you have arterial blockage in the legs, that it will hurt with walking and relieve with rest, and that's called claudication. Unfortunately, this is wrong. This is not the commonest symptom, and this was shown in a large partner study where they took 6,000 plus patients primary care doctors' offices, and they found that 48% of newly diagnosed patients with PAD and about 26% of previously diagnosed were asymptomatic. That is, no leg pain. And the reason they don't have leg pain is because they become sedentary. They stop doing the physical activities that we normally all do. And gradually, when their legs hurt, they become more and more sedentary, so they don't have symptoms. And many of these patients may have atypical leg symptoms, what most of us call neuropathies, that is burning, decreased sensations. And fewer than 6% of newly diagnosed and 13% of previously diagnosed patients presented with classic symptoms of intermittent claudication. So one of the messages that if you can take from this talk is, please don't go by just claudication. You have to evaluate the patients more completely for peripheral arterial disease involving the lower extremities. The risk factors, I think most of you know, and I won't spend too much time on that, but clinical examination of the patient. Well, this was the patient who was brought back for revascularization on July 14th. He saw me on June 28th. He came in and he had a medial malleolus. Hello?
Okay. This is the specialty hospital. Is this Dr. Khusrow?
This is Dr. Niazi and Dr. Latouf here.
Yes. How are you, Dr. Niaz? This is Shireen Abu Manni. I'm the head of marketing and business development. Currently, we're able to see the presentation, but we can't hear you.
Oh, I'm sorry. Okay. Omar, can we do something about that?
What can we do for that?
Give us just 1 second here, and we're going to work on this thing here. Give me 1 second.
Okay, take your time.
Can you hear me now?
We can hear you from the phone, not from the
Oh.
screen.
Okay.
I think we just we're trying to reconnect after that. Give us a second.
Okay.
I'm not.
Let's see. This is Dr. Latouf, specialty hospital.
Marhaba, Doctor.
Lane.
How are you, Doctor?
Can you hear me now?
Yes.
Okay.
We can hear you by phone.
By
but
phone.
we
Let
want
me
to
get
connect so that everyone else can
Let
hear
me
you.
have my engineer here help you. Here's my engineer. Is gonna step in and try to solve it. Zaid.
Hi.
Yes,
To,
Hi.
to solve this, I would ask you to leave the meeting and go back in.
Okay. I think this is what our IT assistant just did. He just left. He just left and you went back in. Yes, but we still can't hear Dr. Niazi.
Can you hear me now?
We can hear you by phone only.
Only by phone.
Yeah.
Okay.
Can solve it.
بدي احطها speaker. Just give us a second.
They have.
Okay.
Can you turn on your speaker phone so that the participants can listen in?
Yes.
Okay.
I think.
Okay.
Can you now to see
if you can use your speaker phone, and I'll let Dr. Niazi continue his lecture, and we'll try to solve this afterwards. Please continue, Dr. Niazi, and thank you, Shireen.
Thank you for your assistance.
So I apologize to the sites that can't hear us because we're having some technical problems. Remember, this is the second lecture that we have organized, so we are trying to work out the bugs, and I appreciate your patience with us. So this was the patient who was a former CEO who came in with a wound on his left leg. His right leg had unfortunately already been amputated. And what test to do? Well, one of the tests that I think all of you should be doing on a regular basis is called an ankle brachial index. This is a very simple test. It's measuring the blood pressure, systolic pressure with a Doppler, not with a stethoscope, with a Doppler in the two upper extremities and also in the foot on the dorsalis pedis and the posterior tibial, and getting a ratio. This should be done very regularly, and it's a simple test with no side effects, and you'll be able to diagnose it. We published a paper in 2006 showing that the utility of the two methods of ankle brachial index, where you measure the pressure in the dorsalis pedis and the posterior tibial artery, and you divide each one of those with the highest arm pressure, and you get an ABI. So the recommendation from that article was that the lower ankle pressure ABI has better sensitivity and overall accuracy in comparison to the high ankle pressure ABI to diagnose peripheral arterial disease. Now, what do you do when you have an abnormal ankle brachial index? Well, if it's less than 0.7, you definitely will have disease. And you can proceed with either an MRA to define the extent of disease or a CTA, or you can do an arterial duplex. In my practice, I proceed with an MRA because it doesn't have any iodine contrast, it doesn't have any radiation. If the ABI is between 0.7 to 1.3, I do an exercise ABI. Remember, your normal ABI is between 1.0 to 1.3. But if it's borderline abnormal, like between 0.7 to 1, I do an exercise ABI. And if it plummets down to less than 0.7, then I proceed with an MRA or a CTA because they will have significant disease. If the ABI stays around 0.7 to 0.8, then I see what the history is. If they have significant symptoms, then I will proceed with either an arterial duplex or MRA or a CTA. If they have mild pain or no limitation, then you can repeat the ABI in a year's time. But if you're really concerned, like in a high-risk patient, like diabetic or somebody who has a wound, you may want to proceed with an MRA to rule out significant disease. And if the ABI is greater than 0.8 and less than 1, you can repeat the test in a year's time. And if the test is ABI is greater than 1.3, it's a non-diagnostic test, which means that the arteries in the ankle cannot be compressed with a blood pressure cuff. And what we do is, since we do with a vascular probe, it's the same ultrasound machine that you do echoes with, we also look at the arterial waveforms. And normally an arterial waveform in a normal artery should be triphasic. That is one positive wave, then a negative, and then another positive wave. And when you start developing disease, you start losing this triphasicity, and it becomes biphasic, and then monophasic, and then it becomes really blunted. And so if you have an ABI that is greater than 1.3 with a monophasic waveform, you know that this patient is going to have significant peripheral arterial disease. So the recommendation on this patient was his ABI was already done in June before he came to see me by vascular surgery on his left leg, and it was 0.79 and 0.68. And they had recommended vascular surgery that you will need amputation of the left leg. Well, as you already know, the patient had an amputation of the right leg, and he was extremely depressed, and he didn't want to lose his left leg. So he left the hospital against medical advice, and his son was a cardiologist in another city, and he talked to him, and he told him to go and see us and see what we can do. So we also got a venous Doppler because we were also afraid that he may have combined venous and arterial disease, and we got an echocardiogram. Now this is his MRA. So you can see the abdominal aorta, the iliac arteries, nice and clean. You can see the superficial femoral artery and the popliteal artery on both sides clean. This is not his. This is just to show you below the knee you should have three vessels: the anterior tibial artery, the posterior tibial, and the peroneal in the middle. And this is his MRA. The right leg is gone, and on the left leg you've got significant blockage in the tibioperoneal trunk. The posterior tibial is completely gone. The anterior tibial is completely gone, and the peroneal artery has another stenosis distally just above the ankle. So we brought him in for revascularization on July 14th. These are his angiograms. Just because of time, I won't let them play in real time, but this is his SFA. This is a popliteal artery, as you saw in the MRA, and this is below the knee disease. He has got severe stenosis of the tibioperoneal trunk. Anterior tibial is gone, posterior tibial is gone, and then further down, he had another significant stenosis in his peroneal artery, and this is the ankle joint where you get these collateral circulation filling the dorsalis pedis and the posterior tibial artery. So we went ahead and revascularized these arteries. We opened up the distal lesion right over here. You can see the arteries opened up, and the proximal area we also cleaned that up. And when the patient came back after this revascularization, after 2 weeks, his wound had started healing. But I told him his wound won't heal completely because he also had venous insufficiency. So we brought him back on July the 30th, and we treated his left great saphenous vein, which was demonstrating severe reflux. On August 26th, his skin had healed up, and when he came back, he was ecstatic. He had lost this leg, but we saved this leg, and he's walking with a cane now. And on September 23rd, the skin had completely healed up. Excuse me. The pigmentation never goes away because it's the iron deposition in the skin like a tattoo, and it's permanent. So a simple workup for physicians, primary care, healthcare providers. If you have a patient complaining of leg pain or they have a wound, most of the diagnosis you can make with a history and with physical examination. And you can lump them into these three big categories. The predominant patients will have venous insufficiency. The next common will be arterial, and then the other causes like skin disorders or cancer. Excuse me. What is the classification of clinical presentation? We normally classify arterial disease in Rutherford-Becker classification. If they have no symptoms, it's class 0. If they have pain with walking, it's 1, 2, or 3, 3 being severe pain. And if they have rest pain, then it's class 4. And if they have a wound, it's class 5. And if they have gangrene, it's class 6. Excuse me. The prevalence of PAD is greater than that of heart failure or stroke, but most of us are more worried about heart failure and stroke. But remember, this PAD is an epidemic, and we shouldn't miss it. And once you develop a wound or a rest pain or gangrene, which is called critical limb ischemia, your mortality, annual mortality is 25%. So if you see a patient today in your office with a wound on the leg which is due to arterial insufficiency, 1/4 of them will not be living more than 12 months. And this has clearly been shown that patients with an abnormal AVI, even if they're asymptomatic, their survival is worse as compared to normal subjects. Finally, I'm going to quickly go through the case 3, and then we'll wrap this up and open it up for questions. I've got 5 minutes left over here. This is a 57-year-old gentleman who came with aching, swelling, and cramps at nighttime. He has had these symptoms for many years, and he was told that the pigmentation of his skin since age 30 was due to his smoking, which is very funny because people don't smoke with their feet. He had also coronary artery disease and stents placed in the past. So in this history, leg aching, swelling, and cramps at nighttime and pigmentation of the skin should suggest to you venous disease. And these are his legs. So you can see this pigmentation over here on both sides. What's the prevalence? Well, I'm going to quickly show the slide. I'm going to avoid the graphics of these things over here. So you can see venous reflux disease is far more common than heart valve disease, cardiac arrhythmias, or stroke, or congestive heart failure. If we combine peripheral arterial disease and venous disease, that even beats coronary artery disease and all the other vascular cardiac diseases that we are concerned about. So it's a very common problem, and all over the world. And as people get older, this becomes more prevalent. So females above the age of 60, 2/3 of them will have this disease, and males, more than 40% will have it above the age of 60. What are the risk factors? Genetics. If your mother or father had chronic venous insufficiency or varicose veins, your chances of developing it are extremely high, 95% probability. And then as you get older, female sex, obesity, pregnancy, prolonged standing, so very common in flight attendants, hairdressers, waitresses, or physicians who stand long periods of time, and nurses, and taller people. What is the venous anatomy briefly? Think of the leg like a circle. In the center is the bone. The bone is surrounded by thick muscles. And these muscles are surrounded by a saphenous sheath, which is this black line over here. And outside of the saphenous sheath is subcutaneous fat and skin. We have two sets of veins. One runs deep in the muscles. Those are called the deep veins. And the other runs in the saphenous sheath or outside, which are called superficial veins. So if you look at a leg, this is the deep venous system. And I won't spend too much time, but you have the external iliac vein over here, the common femoral vein, the femoral vein, and then the popliteal vein. And the popliteal vein is made by the deep veins of the calf. Similarly, you have a superficial venous system in the leg. You have the great saphenous vein, which travels on the medial side of the leg and joins the common femoral vein, and with the femoral vein forms the common femoral vein. And it gives these tributaries called the anterior accessory and the posterior accessory veins. And then you have a small saphenous vein which is behind the calf and joins the popliteal vein, and sometimes it has a cranial extension. And basically what happens is these valves that are supposed to stop the blood from coming back, they develop chronic inflammation and they shrivel up, and the blood starts coming back, increases the pressure in the veins, and they start dilating. So the most common symptoms of these chronic venous insufficiency is not varicose veins. It is the legs feeling heavy, tired at the end of the day, especially after standing, or when you develop cramps at nighttime, which are severe, or you get swelling of your ankles. When you take off your socks, you see rings around your ankles, or itching because of the iron that comes out of the red cells into the skin causes profound itching. You can develop restless legs. You can have varicose veins. Spider veins is not always a sign. You may have spider veins and not have the disease. Blood clots can form in these dilated veins, and if these veins rupture, they bleed extensively because the pressure is like arterial pressure. And finally, you form these ulcers that are hard to heal. How do you diagnose it? It's with a venous ultrasound. This is a picture of a venous ultrasound. The skin is right here. This is the saphenous sheath, and this is the great saphenous vein over here. And this is the muscular compartment below it. And on ultrasound, the blood goes toward the head is blue, the blood coming back is red. And that's how simply you diagnose the test. This is a patient who came to me who had this wound for 2 years. It would come and go, would stay for a few months, then go away. You see this classic pigmentation, you see above the ankle, very classic area for venous stasis ulcers. Once we shut down his great saphenous vein with ablation, the ulcer healed up, and he never had this ulcer back again, which he had been suffering for 2 years. This is another picture. In conclusion, I would strongly encourage all of you physicians to be very leery of these things that when they happen. I think once a wound happens, we have missed we are too late. We should identify this disease. You can tell this is arterial. You can tell this would be a mixed arterial or venous, and this classic pigmentation is a venous disease. So in conclusion, I would strongly encourage patients to screen patients from head to toes for heart and vascular disease, and hopefully in future we can have more of these presentations where we can talk about patients and give you more detail. I'm sorry I went fast, but I've just finished it in 30 minutes, and if any questions, I'll be happy to take them.
Dr. Niazi, thank you so much for an outstanding lecture that you have given. As a cardiovascular expert, I myself have learned a lot from you, but that is not surprising. You've taught me so many things in the past, and this morning you've taught me many lessons also. At this point in time, I would like to open for our participants from around the globe to ask questions. To do so, please send me a message, type your message, and I will recognize you and I will turn you on. I'm going to start by calling on Hebron University and give them a chance to present. Any questions?
Okay.
Dr. Tawfiq?
Sure, we have a question. Sure, Dr. Omar. First, I want to thank Dr. Niazi for a great lecture. I'm sure a lot of people will benefit from this, especially the medical doctors. I will talk later, but Dr. Hisham has a question.
Thank you also for your great lecture. I think it's very beneficial. And I'm an interventional cardiologist, and also always I ask myself when I have a patient with triple vessel disease, I want to send him to surgery, also to examine the carotid arteries or not. What do you think about carotid artery examination in routinely in severely patient with coronary artery disease or asymptomatic patients? In which age or which situation you do?
Dr. Sham, thank you very much. For patients who've got underlying risk factors of coronary disease and they're elderly patients, diabetics, there's no harm in getting a carotid ultrasound. The problem that comes in is healthcare. We have to be cognizant of the cost factor. So that's why we don't recommend doing carotid duplex as a screening test, except if the patient is going for bypass surgery. As I mentioned in one of my slides, some of the factors will increase the probability of underlying carotid artery disease. So elderly patients, or if they have left main coronary artery disease, or if they're diabetics or smokers or peripheral arterial disease, I think your threshold of getting a carotid duplex should be lower. Anybody else with any questions?
Dr. Omar, are you still there?
I think we're fine with the specialty hospital. Thank you for the valuable lecture and the opportunity. Thank you, Dr. Omar, for organizing it, and Dr. Niazi for your time and effort.
You're most welcome. Question for
I don't know if the specialty hospital has questions.
Yeah.
I think we're fine. We don't have any questions.
Okay, well, we want to introduce ourselves. This is Hebron University, and we have great pleasure to meet with you guys at the Specialty Hospital in Jordan.
Thank you. Our pleasure as well.
Great. Well, at the end, since we don't hear Dr. Omar, we want to thank Dr. Niazi for its great lecture. Go ahead, Dr. Niazi, if you want to say anything.
You know, it's a great honor to have Hebron University, Hebron Hospital, Hebron University today. So, hopefully, we can have more interaction in the future. and have a great day, folks. Thank you very much.
Well, thank you very much.
I want to thank everybody for participating in this conference. This has been a terrific opportunity for all of us to participate in this presentation. And I particularly want to thank Dr. Niazi for an excellent lecture. I want to thank Hebron University for participating. And I want to thank a specialty hospital, Dr. Marwan and the American University of Beirut, Dr. Samer in Washington, D.C., and all of those who have participated with us from around the globe. And until we meet again, my gratitude to Khusrow for an outstanding lecture and to all of you. Thank you very much. Have a great day. We'll meet again.
Thank you.
Thank you.